Okay, going over CVA or strokes, there's a few different types. The ischemic, hemorrhagic, TIA. We'll start with the ischemic. So the main thing to really know about that ischemic, meaning lack of blood flow, that is either going to be an embolic stroke, thrombotic stroke. The idea being either it's happening due to clots, causing a sudden occlusion. This is more likely with AFib. So the main thing you want to think about when you have a patient with AFib is that they are also at risk of developing a stroke or an MI, and patients usually take warfarin or Eliquis in order to try to prevent it, which are both anticoagulants, which which makes sense there. The other type of ischemic stroke is due to atherosclerosis, so the buildup of plaque. So buildup of plaque, this is slow buildup over time, but it makes it more difficult for blood flow to get through due to the fact that it's kind of taking up space. And one of the things that is listed here is that TIAs will eventually become this if left unmanaged. So the next one would be a hemorrhagic stroke. So the hemorrhagic stroke is when is going to be sudden, abrupt. It's going to be a lot more acute because because it's going to be direct loss of blood. It's not just the lack of oxygenation due to an occlusion. So it's having a hard time getting to that area. That area is not getting oxygenation. Now you're also at the same time losing blood. Um, and this is typically caused by like an aneurysm that bursts. So an example of one is there's one. Here's like an example of a aneurysm over time for reasons such as hypertension or diabetes, all the smoking, alcohol, all the things that you typically associate with high blood pressure risk. And then with a patient that's not really taking care of themselves there, you can have uh, the continuous increased blood pressure cause a decrease in how well the vessels are able to stay form, and then some of the layers become weakened, and in the blood vessel, there's multiple layers, so one of the layers might break to enough for blood to start pooling and causing what these type of aneurysms like this. And then at that point, sudden changes, sudden movement, sudden trauma, sudden spikes in blood pressure could cause these to burst, and that's when you have a hemorrhagic stroke. There's another picture. When you have at that point a different um the bursting of that aneurysm, the difference in acuity. So the patient will likely just become unconscious, immediately fall unconscious, as opposed to some of the other typical signs of stroke, just due to the severe acuity of it. They have minutes to be able to be treated at that point, so they're going to be more likely to die from a hemorrhagic stroke. The other one is called the TIA, which is a transient ischemic attack, also known as a mini stroke. This is essentially a temporary occlusion. So you can think of a TIA as being similar to someone having angina as opposed to having an MI. So they're getting a temporary ischemia as opposed to the full occlusion. And the TIA is going to have a lot of the similar symptoms, but to a lesser degree. And the thing about it is that it's going to go away. So having a TIA is essentially kind of like having a close call, but the chances of you having a ischemic stroke afterwards is a lot higher because essentially your body already gave you a warning sign. It already had that temporary occlusion. It's very likely that that TIA, that atherosclerosis that's built up, will over time, if whatever diet, exercise, risk, whatever risk factors are in place, is just going to keep going and continue causing increased occlusion until it becomes an actual stroke. The condition that causes the neurological deficit is called reversible ischemic neurological deficit. So keyword there is reversible. So the TIAs don't lead to long-standing deficit. So for sure, you're gonna need to know the BFAST acronym. So out of what you guys know, what does it stand for? What does BFAST stand for? All right, so yeah, B for balance, E for eyes, F for face, arms, speech, and time. So out of all those, balance, so people with ischemic stroke are going to be, or just stroke in general, but the ischemic strokes, you're more likely to actually see the BFAST symptoms. Um, Balance, as in lack of balance. They have what's called ataxia. That's the medical terminology for it. Lack of balance. Eyesight is referring to blurry vision, changes in vision. The face is referring to the asymmetry of it. So having one side droop. When you ask them to give them when you ask them to give you a smile or give you a frown, their face is uneven. When you ask them to um, um, move their eyebrows up and down, that would then be the face part of it. That would then still be part of the face part of it. Their eyebrows aren't able to fully move at the same amount or same distance. For the arms, um, it's like usually comes with unilateral weakness. For the arms, what's recommended is that you ask them to stick their arms out with their palms facing upwards. So somebody with a unilateral weakness, but having their arms stick out with their palms upward, if they have significant deficit, significant weakness, their body will naturally, their palms will naturally start rotating down, and as their arm slowly kind of droops down. But having the palm stick up so you can see that rotation is going to be a more like obvious way of noticing the drooping. So palms sticking up, if they start rotating down, that's a sign of weakness. Speech would be having a hard time speaking or having could also be like having a hard time understanding speech. But slurred speech is like the common thing you hear about when it comes to a stroke. Sometimes it can be very, very subtle. So you kind of want to do a full, like the full be fast if you do suspect a stroke. If you can do it, it's you can get NIH stroke scale training. You can do that for pretty cheap. It's like a certificate that you can have. And it'll go over like being able to basically go through the NIH stroke scale, which is a scale to determine how bad someone's stroke is. And going through this whole thing, you get a number, and with that number kind of gives you a general idea of what you're dealing with, a severe stroke, a not a stroke at all, or anything like that. Sometimes you have patients that are low blood sugar that might have similar symptomology, or like on the surface have similar symptomology, or if not low blood sugar, low sodium levels can cause people to have seemingly neurological deficits. But this is basically the NIH stroke scale. You don't have to memorize it. This is actually a smaller one, but the other one is a bit bigger. But this is like the general idea. So you would see that you kind of do focus on all the stuff that the BFAST is there. You ask for orientation, for how their gaze is, if they're able to have any issue seeing, how well their limbs are able to move, how their sensation is, how they're able to understand language. I think part of the NI stroke scale even comes with those kind of pictures to like be like, hey, what does this look like to you? So here's an example of a picture from the NI stroke scale, and you would be asking questions like, what's happening in this picture? You try to actually ask for very here's part of the picture. Um, no, sorry, part of the picture is right here. Okay, part of the picture here. Like you tell them, okay, so what's going on in the picture? What can you see? You might ask them like specific questions um like who is the one grabbing the like what is the boy doing? And like he's grabbing the cookies, he's about to fall off the stool. So there's a lot of stuff going on here. Depending on the kind of stroke that they have, maybe they're able to interpret some of it, but not all of it. Maybe they see only half of it. They're only able to interpret half of it. That can be a thing with certain types of strokes where patients are only able to acknowledge what they see on their left side, or they're only able to acknowledge their own left side. There's another picture that can be used as well. But yeah, so for the NIH stroke scale, for the certification, if you're planning on going to a higher acuity unit, um, it's like you can get your certificate for pretty cheap, like $10. But if you ever have doubts that the patient might have some neurological deficits, check the blood sugar, check their recent labs, for like a low sodium, do the B fast. If you still feel pretty strongly, you can call a rapid, or it depends on the hospital. Some hospitals will have you call a rapid, and then the rapid response team will call a code stroke. Otherwise, get the charge nurse and then call a code stroke if that's what your hospital policy is. And then the last part of Be Fast is time to call, like time. It's both for like time to call 911 or your RRT, or time for what is your last known well time, the last time that the patient was neurologically there, to their baseline. Okay. Now, going over the differences between like a left-sided stroke versus a right-sided stroke to try to keep it simple. I like to think of the left brain, like L for left, as the logical part of the brain. This one handles a lot of the basic functioning like reading, writing, and speaking, and logical processes like doing math. The right side of the brain, I think of the R as the R in creative. It deals with a lot of the higher level functions, such as like memory, able to emotional and impulsive regulation and balance. So the easiest way I think, to do it is just kind of think of the left brain. If they're having issues with reading, writing, speaking, arithmetic, that would be the left brain, and everything else would be more of a right brain issue. And then when it comes to like left versus right-sided stroke, that's gonna come with opposite side weakness. So if you have left-sided stroke, you're having issues reading, writing, speaking. You would also be having right-sided weakness. If you have a right-sided stroke, this patient would have instead left-sided weakness. I also have this little section. It's just kind of like what's the difference between aphasia versus agraphia. So, aphasia, just remembering like medical terminology. Aphasia is like general language impairment. Agraphia is specifically the loss of the ability to write. So graph, like you're writing a graph, you're drawing a graph. That would be where that comes from. So there's also there's aphasia and there's aphagia as well. Aphagia, like that. With aphasia would be more of a so aphasia is like difficulty being able to speak. Aphagia would be difficulty speaking due to a muscle weakness or the like. So not because they're unable to form the words, but because they're unable to um, unable to move the muscles. Okay. When it comes to the interventions, the main thing that you really need to remember and focus on is that they need to get a CT scan of the head done. So this would be a non-contrast CT scan of the head. And the reason for that is because the treatment for a hemorrhagic, a bleedy stroke, and the difference between a ischemic stroke in the treatment is completely different because one of them is going to want clot busters and anticoagulants versus the other one, which is the hemorrhagic stroke, where if you give them that stuff, it's going to make it worse. So the difference in that will be the thing that makes a large difference in their treatment. So it's one of the most important things that needs to be done. When it comes to that, it needs to be specifically a non-contrast because the non-contrast will, for the doctor, will allow them to see the bleeding better. The contrast might get in the way and make it more difficulty. And then, sorry, up here, I said aphasia. I meant aphasia versus this arthria. That's the aphasia is difficulty swallowing. So this arthria is muscle weakness or difficulty speaking due to muscle weakness. Sorry, the aphasia with the G is actually difficulty swallowing. Sorry. Okay. So when it comes to getting that CT scan, it's usually within like 25 minutes. Uh, the idea would be like within 25 minutes, you want to have a CT scan done within 25 minutes. So that's your golden, like you have like your golden ticket. And then they have the next like 45 minutes to quickly interpret it and start interventions as needed, such as a TPA. But for TPA, only if been cleared of hemorrhagic stroke, and it's only given if it's been less than 3 hours from their last known well time. So last time that they were neurologically there, but only for ischemic stroke. So okay. Other thing would be the NIH stroke scale that we discussed. Vital signs. It's a lot of the time their vital signs will be off. Their blood pressure will be super high. Either um sometimes like the blood pressure can cause someone to have a stroke, hemorrhagic stroke, like 200, like blood pressure over 200 increases your risk of having that. They call it like a thunderclap headache. That would be like the first sign of a hemorrhagic stroke. Or their vital signs if they're bleeding out continuously. Um, so signs of bleeding such as decrease in your vital signs um can be there, or continuing neurological deficits, can changes in compensation factors. Level of consciousness kind of goes with everything else. When somebody has a stroke, they're also going to have an increase in ICP, which is the intracranial pressure. So this will lead to increased blood pressure, and at some point, the compensation factors are also going to be decreased. But as this is a buildup of pressure in the head. So if they're having a hemorrhagic stroke, then this is pressure that could be caused from the blood pushing on the brain. There's a decrease in the space for the brain to be, so it puts pressure as the brain is colliding with the skull. If they had a ischemic stroke, then you're going to be doing things such as antithrombotics, or warfarin, um, or a heparin drip. More likely, it will be a heparin. If they're already on warfarin, you'll continue it if they're having ischemic stroke. Otherwise, it would be a heparin drip. So we know heparin for the subcute, but when it's given continuously as a drip, it's there to prevent the size of any clots if it's an embolic stroke, or just to prevent more coagulation happening. And then warfarin is if they have never been on warfarin before, very likely that they'll be put on dual antiplatelet therapy, or they'll get placed on an anticoagulant later, in which case the heparin drip will be active until the medication is therapeutic, reaches a therapeutic range, and then they'll discontinue the heparin drip. But you can have both of these at the same time as you're waiting for the warfarin to become effective. And then the antiplatelets are going to be effective in prevention of MI and stroke. So your aspirin and then your clopidogrel, which is the Plavix. There is a difference between the antiplatelets and the anticoagulants. Typically, the anticoagulants are going to be a bit better for prevention of venous clots, would be like DVT prevention, which is why you give heparin subcute. While the antithrombotics, like the aspirin, the Plavix, are better for arterial clotting, like strokes, the ones that lead to strokes, the ones that lead to MIs. But evidence-based practice might depend on the condition. So somebody that has AFib and is at risk for strokes and MIs is typically put on warfarin and typically put on like warfarin or Eliquis. But depending on like their condition, they might be on aspirin instead or with the warfarin. If somebody has a hemorrhagic stroke, they're not going to get any of these medications because they're bleeding already. The issue was bleeding rather than having the having the clot or having the occlusion, but they can still get like SCDs if needed. Their body might go into a hypercoagulable state because they're bleeding, so their body wants to then go ahead and clot up. So if that's the case, their body might be more likely to develop DVT, due to the body just being in a state where it wants to clot. So SCDs would be appropriate, or TED-Hos, anything that would be non-pharmacological. We can keep it more localized that way. Patients that have had ischemic stroke, statin medication to control cholesterol, control the buildup of plaque. Medications for hypertension, although it's also worth noting that a lot of patients that had a stroke can be kept on what's called permissive hypertension. Look out for So somebody that has permissive hypertension basically has an order saying that they want their blood pressure to be maintained within this amount of this amount. So it might be that they're specifically looking their blood pressure to be between 150 to 170, for example. So they're they want to be at a higher blood pressure. The reason being that this patient could be, oh, the patient, not could be, the patient needs better circulation to their brain. So the higher blood pressure would be to make sure that there's perfusion happening, reperfusing the area that had a stroke. So if I show you like a picture of a penumbra with a core after a stroke, here's a decent one. So this is the quiz. Basically, the core is where that actual occlusion took place. The penumbra is the surrounding ischemic tissue. So they want circulation at this area, so the blood pressure is allowed to be higher. So if they had like a very severe stroke, they'll turn on like the neuro ICU. They'll have like playing between like vasopressors, management of vasopressors and um, antihypertensive medication, or they could just be on a step down unit. But the idea would just be to try to keep them at higher levels rather than respond to a high blood pressure with antihypertensives. And then, of course, you're providing education. If the patient has a stroke, they want to have like a speech evaluation done. Um, so a speech eval is something that's going to be happening in order to determine if they're able to swallow or if they need modifications to their diet, like thickened liquids, or you need to crush their meds. Um, um, or anything like that in order to be able to actually take their meds. This is kind of like the point where like if they're having trouble eating, might want to be the one to actually feed them if you somehow find the time, in case the patient starts gets to choking or aspirating because of the difficulty with swallowing. And then they'll have a harder time with uh, like their ADLs kind of getting around because of the weakness, so they might need a PT or an OT, depending on the how bad the stroke was. Depending on like if it was like a minor ischemic stroke, they can usually make a pretty good recovery. But it does depend on how fast it's acted out, um, how fast they got 911 help, or how fast the nurse noticed the stroke. So if you catch a big stroke, it could be a very bad stroke, but they could still make a pretty solid recovery if you caught it early. So having that baseline is very important. Any questions so far? We're pretty close to being done. I do have a bunch of questions that we could do for practice. Okay. So kind of following up, the ischemic stroke, once it's been ruled out, we can give them clot busters. So this is RTPA. Um, also also known as Alteplase. That's the brand name. So that is going to be a very powerful clot buster. It's going to be destroying the clot. The contraindications would be, of course, the hemorrhagic stroke. That's why we did the CT of the head. If now they're also having bleeding, if the patient's blood pressure is too high, because then the clot buster part of it and all that stuff. So it decreases the instances of clots. So if you have extreme hypertension, it would also increase your risk of them having a hemorrhagic stroke because even a minor bleed in the brain would not be clotted up. So it would lead to bleeding. You could have hematoma, subdural hematoma, epidural hematoma, no, brain bleeds of some kind. Whether it's slow or whether it's a big one, it makes it a higher risk factor for that, and you don't want to just give them another stroke. Recent surgery would make you less likely because their body already got kind of dug into. They've already, depending on how recent the surgery is, their body might not be able to um, handle it. They might not be able to. They might have recently been on certain medication that they're not supposed to um, be on recently with the RTPA, and then the high PTT and PTINR. So those are the coagulation panels. So though that's already showing that there's a decrease in your ability to clot. Because remember that the PTT and the PT are basically like in seconds. So how long does it take for a clot to occur? So if they're already high, it's already taking a longer time to clot. Same thing with low platelets. So talked about the heparin, that continuous infusion. If they have brain swelling, they can get osmotic diuretics to reduce the brain swelling. Examples of this include mannitol, 3% normal saline. It's also called hypertonic saline, HTS. You will learn more about this in the next semester. Next semester, you have a week that is focused on hemorrhagic stroke and hematomas. So you'll go over in detail more at that point. For long-term therapy, and this is all still for ischemic stroke, long-term drug therapy includes antiplatelet medication. Like I said, the aspirin, the Plavix are the most common ones. There's this other one that I've seen, the Persentine. Let me see what the uh, diparatamol. The Yeah. I haven't for the most part though, it's gonna be Plavix and aspirin. This one's more rare. For anticoagulants, the Coumadin or warfarin, the Lovenox, Eliquis could be one. Because they had pressure either. Oh, I guess at this point, if they had like brain swelling, they are at higher risk for developing a seizure. So anti-epileptics, uh, Keppra is an example of one. I might be given. Even like in the short term, it could be given if they're at really high risk of stroke and then discontinued slowly after. And there's also the use of calcium channel blockers for prevention of a few different things. It helps to prevent vasospasms and then manage blood pressure. And then the vasospasms are something that can also actively occur in the recovery. Um, in someone with an increased intracranial pressure. Although, granted, when it comes to um, this, like, it does have that recovery phase. It's not like a super long lasting thing. And if it is there, if it's super long lasting and it's not unmanaged, then not getting any, they're not getting any perfusion, in which case they'll be brain dead. But as long as it's acted upon, the intracranial pressure will go down over time as you're treating as you're treating the symptoms, treating the occlusion, you clip the aneurysm, you're managing the brain swelling, but during that time period of recovery, they have an increased risk of the vasospasms happening, which would continue to increase the pressure in your head, which is not good because we want to make sure that that's managed and that we have proper perfusion in the brain. For a hemorrhagic stroke, there's going to be surgery. You're going to want to clip it, coil it in order to get rid of the aneurysm. That vessel becomes sealed so it doesn't bleed anymore. They might get a EBD shunt. So an EBD shunt is, I'll show you a picture. It's this device that's in the head. It allows you to drain some cerebrospinal fluid in order to help manage some of the swelling in the brain. So it's a way to help manage some of that pressure that builds up in the brain, that increased intracranial pressure. And either way, you'll also get osmotic diuretics to decrease brain swelling. For the neuro part, you're gonna be doing like your neuro checks. Could be Q1 hour neuro checks. So that would involve their Glasgow Coma scale. It involves the NIH stroke scale. How are their vital signs? What's their baseline compared to their baseline? And then for positioning, head of the bed slightly up. Try to keep it all aligned. No like excessive bending or anything. Uh, you just want to maintain that intracranial pressure a bit more consistent. And here is this is kind of like what I was referring to before. Kind of over here. Explanation of like the vasospasms. So cerebral vasospasm. This would be for like I guess this is put under ischemic stroke, so this would be more like, put it right here. Calcium channel blocker. Basically the same thing though. This one specifically mentioning the subarachnoid hemorrhage. That's one of the type of hemorrhagic strokes, subarachnoid hemorrhage. Um, the calcium channel blocker that's usually used is nimodipine, which is called Nimotop. So it's just kind of the specific one that's used to help prevent vasospasms because the vasospasms could make, think, the ICP worse. But for the most part, when it comes to this class, it's usually focused more on the ischemic stroke part of it. Next semester, you'll have, again, like that whole section that's based on, that discusses the hemorrhagic, the bleeding, the brain bleeds and the hemorrhagic strokes. Any questions on this at all? Okay. So like I said, I do have some questions here. Um, since this didn't take that much time, we can go over the questions if you guys want. Do you guys want to go over the questions or just kind of take it, do it on your own time? It does have rationales at the bottom. Okay. So we can do some questions. So let's see. Number one, let's see. You are caring for a recently admitted patient. Which clinical finding is the earliest sign for increased intracranial pressure? Yeah, so we're gonna go with headache here. Another really good answer, other than the headache, would be altered level of consciousness. So, um, out of the ones listed, um, the headache, it'd be like between the headache and the change in change in cognition. So, altered level of consciousness and headache are the um two earliest signs of increase intracranial pressure, which makes sense. You have increased pressure in your brain. Let's see here. During discharge, teaching for a patient who experienced a mild stroke, you are providing details on how to eliminate risk factors for experiencing another stroke. Which ones are modifiable? So which ones are you able to educate on for modifiable that they're able to actually change? Select all that apply. Okay, so we have A, D, and E. That is correct. So smoking, we can recommend smoking cessation. We can recommend changes in their lifestyle. So just keep, you pretty self-explanatory, but you might get questions about like which risk factors are modifiable or not. So you can kind of take that logic, like anything that they can't change is non-modifiable, as the definition of the word is. But you might get a question like that, even if it's not for this, but for a different thing. Um, it's like select all that apply. Your patient has expressive aphasia. Select all the ways to effectively communicate with the patient. Select all that apply. So aphasia is having a difficulty communication. Expressive meaning that they're unable to generate. Yeah, B and C is correct. They're unable to generate the proper speech as opposed to interpret like a I don't remember. I don't think it's called interpretive aphasia, but let me see. Aphasia, difficult understanding. Uh, what's the other one called? I think it's just called like a interpretive aphasia. The other one would be having a hard time understanding. So here they're having a hard time expressing themselves. So so you want to ask questions that you're able to get maybe like a yes or no, because like they're having a hard time actually getting the answers out. They're understanding you all the way. Using a communication board if they're able to have an easier time writing. Uh, if they have a hard time, like with aphasia, they might also have a hard time writing, but it all depends on it does all depend on like exactly where that clot is. They can have some of those symptoms that are listed under like the left-sided stroke. They might have more than some might have more than the others. Some might have it worse in one zone than they do on the other. So this person might have a harder time speaking, but an easier time writing, even if there is a deficit in writing or not. Okay. Well, speaking with a patient who had a stroke 6 months ago, you note their speech is hard to understand and slurred. This is known as what? Whether, yeah, dysphasia. So don't make don't make the mistake I did when I was talking about it earlier. Dysphagia with the G is difficulty swallowing. Um, so dysphasia. So just make sure you're familiar with the medical terminology because they'll bring out, that the medical terminology of it, and you'll want to make sure that you understand. Because like it's one thing like if they write it like, oh, it's difficult to speak, oh, it's difficult to balance, difficult to read. Versus using the medical terminology, you might be like, you might know the answer, but you don't know the medical terminology for it. So that's that, but it's easy question otherwise. You're reading the physician's history and physical assessment report. You note the physician wrote that the patient has hemianopsia. What assessment finding correlates with this condition? So hemianopsia. Yeah, so we didn't even discuss over that, but hemi meaning half, a meaning without, or an meaning without, and then opsia referring to vision. So this person is having a loss of vision, ha that half loss of vision. So this would be related to like sometimes people have a stroke. They know they lose function in one half of their body. Uh, so this person can have um, difficulty like interpreting, either seeing or interpreting like what's happening in the on that side of their body, like what they're able to see on that part of their body, um, which is why they also have like the pictures. Like they might be able to interpret stuff that they see on their left side, but they're having a harder time on the right side and vice versa. So that's what that word is if you see it. 6, you need to obtain informed consent. Patient experienced a stroke 3 months ago, unable to sign. Which one's this? Yeah, so agraphia, graph, you're writing a graph, you're drawing a graph. Um, so just for the sake of making sure we're good with our medical terminology there. Okay. So now, you don't expect questions to look like this, they're not going to be like, what's the definition of, you guys know the drill at this point, but just to make sure you guys have the medical terminology aspect of it. Okay, so in order for TPA to be the most effective, when must it be administered? I very, very briefly mentioned it. Yeah, so you have that 3 hour window of their last well known time, or last known well time, or otherwise known as like when did that stroke start to become noticeable. That's the 3 hours for it to be the most effective. Otherwise, they don't give the RTPA because it would be considered like the risk is higher than the reward, because it's like, okay, if the last known well time was 3 hours ago and you're still alive, part of it part of it has kind of like self-managed itself, and the RTPA is introducing more harm than good at that point. Okay. 8, you're assisting a patient who has right side hemiparesis and dysphagia with eating. I shouldn't have said that. I could have just put this. I guess it's specific. Eh. But it is very important to blank. Yeah, so this one's going to be B. So if somebody is having, so hemiparesis, hemi again meaning half, paresis meaning state of paralysis. So half of their body has weakness. It's not necessarily like fully paralyzed, but it's gonna be like have that right, like that half-sided weakness. So they're having right-sided weakness, and they're having difficulty swallowing when they're eating. Although dysphagia can also occur even if it's like their own like spit. They might choke on their own spit. Um, but in that case, when they're eating, you want to make sure that they're not there's food that's not accumulating on their right cheek, because then at some point they get moved, or they move their head or something, and then that small amount of food might go down their trachea instead, so they can aspirate. And then here, this thing says prevent aspiration by thinning the liquids. You want to thicken the liquids to actually prevent the aspiration. That's what's going to help to prevent, not thinning. So just look out. If you're in a hurry, make sure you read all your answer choices and whatnot. Number nine, a patient has experienced right-sided brain damage. You note the patient is experiencing neglect syndrome. What nursing intervention will you include in the patient's plan of care? So if you don't know what this is, I'll explain it. Yeah, the answer is A. So neglect syndrome, kind of in the name, but this would be like they have right-sided brain damage, so they have left-sided weakness, all the stuff affecting the left side of the body. They can also have left-sided neglect, so it's almost like in their head, their left side is no longer a part of their body, and they neglect it. So, for example, if they're brushing their hair, they might only brush the right side of their body as opposed to the left side because in their head, um, for whatever reason, it just the body uh, the brain chooses to start neglecting their left side. So they might just only do things to the right side of the body. Um, and again, it kind of does correlate with opposite sides. So right side of the brain got damaged, the left side will have the deficits, and vice versa. So here would just be patient education on um, incorporating that part of their body to help mitigate the effects of the neglect syndrome that can occur. Okay, so number 10, which of the following are signs and symptoms of a left-sided stroke? Select all that apply. Yeah, so this is going to be A, C, E, and F. So just remember left-sided damage on the left side leads to weakness on the other side. Kind of like how they say like people that are left-handed are very creative, and that kind of goes people that are left-handed that left-handedness comes from the right side of the brain, which is the creative part of the brain. So it's like they just kind of opposites there. C would be the aphasia, difficulty speaking, the agraphia, the alexia. So the three, like the logic, right? The L for logic, the basic functions. Well, everything else that you see would be a right-sided stroke. So if they asked this exact question, but it was for a right-sided stroke, you'd be looking at left-sided weakness, things involving um, ability to control your emotions, control your expression, ability to remember, so altered memory, impulsiveness, ataxia, which is balance. So the balance is also controlled by the right side of the brain. So if you get this exact question, but like the right side of the brain, um, if you're having a hard time remembering, you can also just think of which ones are left side brained, and then everything else must be right side brained. But I would probably expect to have a question similar to this. Okay, and then the last one, this one's a open response, but this is what is the biggest priority? So you have a patient that's suspected of having a stroke. What is your biggest priority once you bring the patient into the hospital? Perfect. Yeah, so you're gonna want to do that CT scan as soon as possible, specifically a non-contrast. So if for whatever reason they give you a choice between a contrast CT and a non-contrast CT as opposed to just being like CT, you want to pick the non-contrast because the contrast gets in the way of seeing bleeds. So if for whatever reason that comes up, it probably won't. It becomes a point in case for 240 because they specifically are going over hemorrhagic stroke. But The main thing here is CT scan within 25 minutes. So that's going to be your biggest priority because then you determine, do they need TPA or can they have TPA? Do we need to use non-pharmacological interventions for prevention of BTE? And do we need to go into surgery to clip an aneurysm? How much time do we have? Um, the acuity does change. And then some of the treatment like anticoagulation, antiplatelet therapy depends on if they're having a hemorrhagic versus an ischemic stroke. And then your assessments, you're doing NIH stroke scale, you're doing Glasgow coma scale, neuro checks, the altered level of how conscious are they? Like, they know their name, date of birth, et cetera, et cetera. Vital signs, how are the vital signs looking like? Do we have an order for permissive hypertension? So what do we got to do to keep their blood pressure within this certain amount of levels? Do we have medications on board in case the patient has a vasospasm? The vasospasm, like cerebral vasospasm, literally like the vessels start spazzing out. They will cause an increase in blood pressure. It will cause a decrease in functioning because you're having your vessels spasm around. So you might have like altered level of consciousness there, altered level of consciousness there. And then earliest signs of increased intracranial pressure include altered level of consciousness and headache. Okay. So with that, I'll give you guys both the files, but if there's any questions, feel free to type it out, type it in the chat.